Welcome everyone to the United States of Care webinar, Actions to Plan, Prepare, and Prevent COVID-19 Surges. I'm Crystal Jacobson from United States of Care. Before we begin, I want to run through a few general housekeeping items. We will be recording this webinar, and the recording and transcript will both be available on our website, unitedstatesofcare.org. All attendees have joined in a listen-only mode. And the format for today's call will be 5 to 7 minutes for each of our presenters, followed by an open Q&A. At the time of the Q&A, we'll provide instructions for how to ask your questions. Lastly, if you experience any technical issues during today's webinar, please email user, USER, at usofcare.org. My colleague Destiny is standing by, and we'll do our best to troubleshoot any issues. Thanks for your attention. Again, welcome to this United States of Care webinar. I'd like to now turn it over to our Senior Policy Director, Kristen Wakilius. Kristen?
Thanks, Crystal, and hi, everyone. As Crystal shared, I'm Kristen Wakilius, USofCare's Senior Director of Policy. Also on the line from USofCare is Natalie Davis, our Senior Director of Public Engagement, and she will help facilitate our Q&A session. It's my pleasure to welcome and thank all our speakers for joining us today and sharing their expertise. I'm honored to introduce them. Andy Slavitt is a former acting administrator of the Centers for Medicare and Medicaid Services. He's the founder and chairman of Town Hall Ventures and founder and board chair of United States of Care. Ryan Pedchadsaram is a co-founder of US Digital Response and the creator of COVIDExitStrategy.org. Dr. Rebecca Gee is CEO of LSU Healthcare Services and previously served as the secretary of the Louisiana Department of Health. She is also a United States of Care Founders Council member. Jason Elliott is senior counselor for housing and homelessness under California Governor Gavin Newsom. We're so pleased to have all of these speakers with us today. Regardless of where states are currently in the trajectory of the pandemic, now is the time to take stock of what we've learned in the first few months of the COVID-19 response and to plan for subsequent waves. As part of our work supporting states in their COVID response, United States of Care has compiled a state preparedness handbook with 5 actions that leaders can take now to help address future waves of the pandemic. First is listen to the needs of different communities. In our own listening work, we're learning that people are putting concerns about the health and safety of loved ones ahead of their own and are concerned about their community and those that are on the front lines. State leaders have a real opportunity to craft the next phase of their COVID response based on the needs of those who are most impacted if they listen now. Second, communicate clearly with people and use data to guide decision-making. Leaders need to establish clear channels for making decisions, which will allow them to act quickly in response to future spikes. Leaders also need to be creating a data-driven early warning system, which is critical. States need effective monitoring and clear benchmarks for action to be able to quickly identify areas when and where the virus surges, with the goal of keeping any shutdowns as targeted and as limited as possible. Ryan will talk more about some of the data that states can use, such as hospital and ICU capacity, as they monitor the virus in their state. States also need to use proven tools to respond to what the data shows, with sufficient testing capacity and the ability to trace contacts of those that are infected. Leaders must also share direct, timely, and accurate information about what people can expect. Ultimately, people want clear and actionable information from trusted sources, even if the news isn't good. And effective communication in a pandemic means finding not only the right message, but also the best messengers to effectively share it with different communities. Third, focus on protecting people and places that face the highest risks. We now know much more about who COVID-19 impacts most severely and the types of settings that are most at risk. Any successful pandemic response must focus first and foremost on the people and the communities that have faced longstanding barriers to accessing care, including the Black, Latinx, and Native American communities hardest hit by COVID. This means that states must address disparities using a comprehensive approach, understanding the experiences of vulnerable and at-risk populations, especially communities of color. States should be acting now to protect and fortify the locations that have proven to be a high risk for transmission, such as nursing homes and long-term care facilities, jails and prisons, and other congregate settings. Future waves of COVID could bring additional school closures. And as part of planning for potential closures, officials must plan for disruptions to key services to ensure that the programs that children depend on, such as mental health care services and access to healthy foods, are available. Plans for COVID surges must also recognize that not everyone can safely or effectively isolate in their home if exposed, and create a system of isolation and quarantine for those who need it. During the initial wave of COVID-19, many states and localities have established unique isolation and quarantine approaches to provide safe temporary living spaces, often with wraparound healthcare and behavioral health services. Jason will be able to discuss some of California's work to meet these needs. As people return to their jobs, we must ensure that they are safe at work. There is much we can do to keep both workplaces and schools safe to help prevent future outbreaks, work that Dr. Gee has helped lead that she'll be able to share later. Action 4 is to build health system capacity to meet people's needs. People want a health system that is well-resourced and will be there for them when they need it. The first wave of COVID-19 exposed cracks in our preparation and left people concerned that our system was not actually ready to care for them. People expect to see a better response moving forward, and now is the time to fill gaps that were evident in the early days of the response. States need to establish systems to quickly ramp up the availability and distribution of PPE through regional partnerships and coordination. Sustaining the healthcare workforce will also be critical to ongoing success. Workers on the front lines will need ongoing support and robust mental health safety net. New York, for example, is waiving out-of-pocket costs for mental health care services for frontline medical workers. States should also plan to take a targeted approach to delaying non-essential care and procedures if surges in COVID occur, in the hopes of avoiding blanket delays to healthcare services that people also need. And finally, as leaders do this planning, they need to recognize that they may be addressing future waves of COVID on top of other external events, most notably seasonal flu. States need to plan to maximize distribution of influenza vaccines in safe settings, focusing on the most at-risk populations. Fifth and finally, states should act now to build the public-private collaborative approaches that will help them be successful. Cross-state and cross-sector partnerships have been an integral part of the success of the response to the initial outbreak. And now is the time for leaders to work to build the partnerships that will help them succeed in addressing what comes next. By taking these 5 actions now, the response to future waves of COVID can minimize the need for a full-scale lockdown and future stay-at-home orders. For more information on any of these items, our State Preparedness Handbook is available on the USofCare website at unitedstatesofcare.org. And with that, I will now turn it over to Mr. Andy Slavitt to say a few words.
Thanks, Kristen, and greetings to everybody. First, I want to just thank the United States of Care team for the amazing work that you're doing to help states figure out how to open safely in ways that can help make sure that people are both healthy and we get the country moving again. I also want to thank everybody for tuning in today. I know people are busy. And finally, I want to thank anybody who in any way has supported the work of United States of Care, either by bringing expertise, by signing up to get on the website to get emails, or financially supporting the organization and the work that they're doing so that they can continue to do work like put out the materials that Kristen just shared with you. Let me just start for a second by telling you what it is that we believe at United States of Care. Our belief is that everybody, no matter who they are, no matter what they look like, no matter where they come from, should have a regular source of care that's theirs, that takes care of them, and that our country owes us nothing less. Second thing we believe is that people shouldn't have to worry about how they're going to take care of their families if someone gets sick, that there should be financial protection for everybody, table stakes. Third, we believe in a system that is equitable and just. And equitable doesn't mean everybody gets the same thing. Equitable means people get their needs met how they need to get it met. Fortunate to have people like Kristen who put all of those principles into actual policies. People like Joanna Dornfeld who bring those policies out to state and local leaders. People like Andrew Schwab who bring that to federal government leaders like in the Congress. And really people like my co-founder, Natalie Davis, who make sure that every bit of our work is actually grounded in solving real problems for people. And I think that's one of the things that you'll see different. So let me spend a second before we turn it over to the panelists to talk about what is going on. Over the last 24 hours, I've been having a number of phone calls with states who are more and more concerned. These are states in the South and in the West that have, for some time, not believed that this virus was going to come to their communities, and now are starting to see that. And I want to just say a couple things. First of all, the question I probably get asked most frequently is, okay, whose fault is this? Who do we blame? Do we blame people who went and had barbecues on Memorial Day? Do we blame protesters? Do we blame the president? Do we blame the governor? And the truth is, if you want to blame anybody, we should blame the virus. This is how the virus behaves. This is how it behaves biologically. It goes from community to community, finding gatherings of people. Then it hosts itself inside largely asymptomatic people until it finds people that it can attack their organ system and their blood vessels. That is the true bad guy here. And if we begin every conversation by just thinking about what divides us and who's to blame, I think we'll get it wrong. I think we won't help each other. I think we won't support each other. I think we won't come to the right answers and conclusions. And yes, political leaders are responsible for how they reacted, and not everyone has reacted well. And by and large, if you could compare our reaction in the US to reaction of countries overseas, whether that's in Europe or in Asia or in Oceania, our reaction has left a lot to be desired. So we're not going to pull any punches that we can do better. But doing better means all of us. It doesn't just mean our elected leaders, and it means getting into these topics in a fair amount of detail. I do believe we can live with this virus. I don't believe that we have to stop enjoying our lives. I don't believe that that there aren't a lot of really great activities we can't all do. But I do believe that there needs to be the political and governmental support that allows people to do that. Things like paid family medical leave, things that provide all kinds of levels of support, and that those things, I think, are things that can be arrived at by doing the work, by looking at the data, by focusing on communities and reaching the kinds of conclusions that Kristen just laid out. So we feel like our job is to help do that work in an impartial and trusted way, to work with people no matter who they are, no matter what their other beliefs might be. But their view is if they want to protect the safety and help their states, then we are ready to dig in with them. And I'm so appreciative for those that allow us to do that. So with that, I'm extremely excited, like everybody else is, to hear from everybody else. I know that Kristen's going to introduce people shortly. I have had the benefit of having worked shoulder to shoulder with Ryan on many, many occasions. I've had the privilege of working with Dr. Gee very closely on many occasions, and I've just met our third panelist, and I'm completely blown away with the work that he's doing. So I think we're in for a good conversation.
Great. Thanks so much, Andy. And I will pass it over to Ryan for an overview of COVID exit strategy and how some of the data is looking.
Thanks, Kristen. Can you see this? Fantastic. So
We can.
we started this project, COVID exit strategy, to help state leaders and the public better understand how their state's doing in tackling this virus. Where, as a reminder, we're a nonpartisan group with experience working across multiple administrations, made up of volunteers from the U.S. Digital Response, United States of Care, Resolve to Save Lives, and Duke's Margolis Center. And what we do is we aggregate publicly available information to track a state's progress toward the reduction in symptoms, their health system readiness, and testing throughput. Our primary data sources come from the CDC itself, as well as this project called the COVID Tracking Project, which collects information from state government websites. They check them every day and aggregate that for us, and we present it this way. And this site that you see here is meant to be a progress bar for how the country's doing. And as a reminder, our dashboard here is only as good as what's being shared publicly by federal, state, and local governments. And so we depend on them, and we can present the information in this way. And with the few minutes that I have, I was going to give you a quick tour of the site, which effectively is giving you a quick tour of what's happening across the country. And so when you scroll down to the main section, you can start to see how each state is doing on key measures. And with our working group, we've surfaced these measures here. Most importantly, actually, when I say most importantly, these are the most important ones, and you have to look at them all in context, because one measure doesn't completely tell the whole story. And so we track what the trend is of cases is looking like. And so you can tell if it's increasing, decreasing, or flat. We pull data from the CDC on what the influenza-like illness syndromic system is saying. Right now, actually, across the board, it's quite minimal, right? Because we passed flu season a long time ago. We also track this idea that there is a target of testing that we should have across the country. And this main one here looks at this 500,000 tests a day number that both Harvard as well as Resolve to Save Lives and the Rockefeller Center have rallied around as a baseline. We need just this many tests to get a sense of what's happening. But there's a far higher target of 4 million a day that we need to get to. And so this is tracking how a state's doing on that 500K. We look at ICU availability, which is released by the CDC. We try to calculate out what the cases per million per day look like, right? It's an inference of what the burden on the health system is going to look like, as well as we look at what the COVID positive rate is. And that's important because it tells you how well you're testing. And so if you look at this high level view and say, well, which states are doing really bad, I've created a quick view here that pulls all of those out. You know, in the news, many of these states are there, but the one that's clearly at the top with cases increasing incredibly is Arizona. They've got cases increasing over 150%. They're testing better than they were before, but their cases per million rate, as well as their positivity, is really high. And this piece here is the alarming side, right? The case positivity of COVID positives at 22% in Arizona. That means that for every person they're testing, as you test more people, the idea is that positivity rate should go down, right? You're testing more people and you're finding people that are not positive. But if you're testing more and you're finding more positives, it means you're not testing enough. And so that's for Arizona. You can see other states that are on maybe the different spectrum, like a Hawaii, which is tagged here as red because you've got cases increasing, but it's at a completely different level of cases per million, right? In Arizona, it's 375. In Hawaii, it's 8. And so, when you look at this site, use the data that's there to help set that context. If you ask another view of, well, how are some of the good states doing, right? The states that are decreasing, you see a consistent pattern of cases decreasing, really high testing, very low cases per million, and a positivity rate lesser than 5%, right? Versus the 22% in the Arizona case. And so quick, easy things is if you just type any state in, it'll help you filter these things out. If you type in multiple things, it'll let you pull those pieces out there. And so this tool is really helpful for journalists or folks on Twitter or researchers. If you want to pull out a subset of states, you can do that. A few sections to call out. There's one that tracks how a disease is spreading. This looks at the zoomed out view. What is the RT, which we pulled from RT Live, and what's the doubling time? A lot of folks spend even more time on this section here, which is, can our health system handle the spread? right? Our ICU and bed availability, what do the cases per million look like? What is hospitalizations per million, as well as what the case fatality rate is. You can sort some of these sections to get a better sense of what the state of the state is. And you can see here when it comes to cases per million per day, right? This is adjusted per capita. You've got Arizona, South Carolina, Arkansas, Florida, Utah, and Texas all at the top. You turn that on its head, you can see places like Hawaii, Vermont, Montana, and Washington on the bottom. The other section to call out is this one here on testing. Testing is so important, right? When I talked about those two targets, you can see them here side by side, how a state is doing towards that total 500,000 per day, as well as how it's doing on that 4 million per day. You can see the positivity trend, which is really important, right? You got to look at both sides of this chart to get a sense of, are we testing enough? So as these increase, this number should be decreasing. And if it's not, it means you have to test more. And so as a team, we're working on how do we help set maybe a different kind of threshold for this upper bound, right? Because if a state isn't finding any cases anymore, well, then it can test less. But if a state continues to find more, this target actually should rise accordingly to the number of cases they have. And so this site here, we update every day, every night, as soon as all the data comes out from the CDC and COVID tracking project. We've got a lot of work underway as well, too. There's a section on the site, which is us trying to faithfully assess each state on how the CDC categorizes each of the most important categories, right? They call them the gating criteria and indicators. And so if you explore this section, we're working over the next few weeks to pull it into the main portion, but you can see how the CDC is looking at these things. You can see here on the category of cases decreasing from a CDC's point of view, the states in red are not meeting their criteria, whereas the states in green are. And this uses a different way of calculating how you smoothen out cases. Most of us online that are doing these calculations do it as a 7-day rolling average or a 14 or a 3. But the CDC looks at it a little bit differently using this thing called a 3-day cubic spline. And so we've adopted that model. And it's a really nice model that helps smoothen things out. And so you can see how they're looking at things. You can see how they're looking at the decrease in percentage of COVID positive tests, and you can see which states are passing that. You can see how the visits for ILI are looking state by state. You can see how treating all patients without crisis care from their point of view, and as well as like what a robust testing program looks like. And so we've got a lot of work to do here on this part, and we'll pull it all into the main section once we're ready. But I hope this can be a tool and useful resource for you. If you have any feedback, please feel free to send it to us. We listen and read to every single email that folks send, and we try to keep improving the site, because ultimately we've built this for you as a state leader, as someone that can influence states and the decisions and policies that may make. And so with that, Kristen, I'm going to hand the baton back to you.
Thanks so much, Ryan. And just a quick reminder for the audience that we will open this up to questions for all of our panelists after their initial presentations. And now I'd like to pass it to our next speaker, Dr. Rebecca Gee. Dr. Gee.
Hey everyone, I want to thank USofCare. It's an honor to be on the Founders Council, but also to personally thank Andy. Andy, you've answered calls on nights and weekends. You've connected us to resources. I know you sprinkle fairy dust over every state in this nation, and you're doing great work, and you never take credit for it. You're just trying to make good things happen for the people of our country. So thank you to you personally for everything you've done for our state. Now, look, Louisiana is an outlier. We're a positive outlier. Why? We are a Deep South state. We are the only Deep South state to have expanded Medicaid, and I think that that decision to expand Medicaid and the public support for that decision explains somewhat of why we're doing better. In Louisiana, we have a culture that whether you're Black or white, rich or poor, you eat red beans and rice on Monday. We love our music. We get hit by hurricanes, and when we get hit by hurricanes, they don't distinguish based on who you are. We have to pull through them together. So I do think that that culture, whether it's our beans and rice or our music, ties us together in ways that other states in the South are not. And that being said, we are, I'm going to say where we are now. Where we were initially was we were severely hit. At one point in the first 2 weeks of the epidemic in the New Orleans region, we had an 87% increase in COVID cases. That was higher at that time than the nation of Italy or New York State. We were 2 ventilators away in one of our hospitals from running out. So things were incredibly serious. The virus was invisible at the very time we had Mardi Gras and other large public events and many tourists from all over the world in our state. And the virus spread here very rapidly and impacted low-income, vulnerable populations disproportionately. But we have a governor that people trust, and he had a public health leader by his side, Dr. Alex Biu, who has done a phenomenal job communicating. And we had done the work when I was health secretary of communicating with the public about data and really putting in a lot of effort into those data systems. So Louisiana, and I'm sure there are other states that have great ones. I think ours is the best. I'm biased. Some of the work that Brian just said, we have for Louisiana, we had it very early on. We were the first state to report, for example, health disparities in COVID as a state. We were the first state to have an integrated dashboard that showed ICU beds, hospitalizations, number of cases, number of tests. And the data that you just saw showed that we're in the top 3 states in the nation on testing. We had preserved our public health capacity, and so are able to ramp up testing in partnership with the private sector in ways that other states have not. And I do think that local public health leadership is a part of our story as to how we got out of that initial crisis. We unfortunately are looking like a U shape now. The numbers that had gone down so dramatically are now going up, and we're looking like some of the rest of the country. I call it COVID fatigue, or in other words, we feel like we're done with COVID, but unfortunately, as Andy so well stated, COVID's not done with us. It's an equal opportunist, regardless of your political affiliation. But there have been success stories in terms of public action. We have here in New Orleans, people are very bought into face masks. We've been very clear about 4 simple messages. People, limit the number of people that you're around. Space, limit how close you are to other people. Where are you, inside or outside? Outside is better. And then time, how much time are you spending? Really some good messaging. We have a lot of work to do, and LSU is leading the way on working with Latinx communities and communities of color who understandably have tremendous issues of trust with communication that comes from the government. And so we're looking at working in non-traditional ways on communication and have made some good strides, but still a lot of work to do. I just wanted to highlight 3 key challenges. One is on the, where are we in terms of guidance? Well, we're in a phase 2 in Louisiana. We're not moving forward because of how our rates are looking. There's a lot of clarity on industrial hygiene practices and how do you clean and how far do you space and what restaurant tables look like. And I think there's a lot of public comfort around that. I wanted to highlight the American Association of Industrial Hygiene and their website, backtoworksafely.org. In an ideal circumstance, you would have had an OSHA and a NIOSH and a CDC that would have very early on put out clear common sense guidelines. That did not happen. In the absence of that, these organizations like AIHA have done some tremendous work, and I would encourage you to look at backtoworksafely.org where you can see bar industry, at-home service providers, dental and childcare guidance. And we worked very early on with them, along with our restaurant association here, to make sure that we were optimizing these hygiene practices. I mentioned testing earlier. We're doing a fantastic job on testing. We remain one of the top 3 testers in the country, and the District of Columbia as well. We still have challenges. There's a lot of disagreement on protocols, whether it's for institutions of higher learning or a restaurant setting or a tennis club where somebody's teaching kids has COVID, or it's a bus driver. But that being said, there needs to be alignment there. We're doing the best job we can, but nationally we need to be more solid on our recommendations. And I've been trying to work with the National Academy of Medicine, who is putting out guidelines in July on K through 12, which will be fantastic to have that level of scientific leadership. But where we're really having a challenge at this point is the contact tracing. Contact tracing is that shoe leather, classic, just need to do, done for tuberculosis, has been done for HIV and other sexually transmitted illnesses. There's a lot of problems with contact tracing, and our state is one of the best in terms of our plan. We have hired nearly 700 contact tracers. Our state's Office of Public Health is leading the effort. They are paid individuals, so we're not relying on volunteers. We've got centralized calling centers. We're working across the public and private sector. However, the public trust isn't there. And that's a problem we need to solve. Although about 60% of people are answering the calls, which is great, most of them are not being honest about how many people they've been in contact with. We're getting a lot of responses, oh, I wasn't in contact with anyone. And that for most people is not the case, particularly before they knew they had COVID. So we've got to do better on our messaging and our public trust around contact tracing. There also needs to be alignment around common apps. Google and Apple have been tremendous leaders in this space with their Bluetooth technology that allows you to see where you've been in relationship with others who have COVID without having to document where they've been using this new technology. And we're working as a state across all of our institutions of higher learning and with the Office of Public Health to have one single app, which will minimize the redundancy in terms of contacting people and will allow us to better translate that data into action at the state level. So all of that's happening, and more work needs to be done, but the good news is in our state, we're pulling through it together. I just also wanted to outline a couple of other efforts that have been very helpful and collaborative. One is on the protective equipment. Early on, many of us were involved in looking at protective equipment, and there have been private sector or non-governmental approaches to this, like Project N95, that was very helpful. Then there are good COVID resources for doctors through the AMA. There are guidelines for employees and workers through the WHO. And then the CDC has come out with some guidelines on how to disinfect workspaces, but arguably they're not optimal or ideal. We have a lot of work to do as we continue to fight this epidemic to reduce disparities and ensure that vulnerable communities are those we go to first. The stimulus bill ignored some of the systemic problems, structural problems in our country that Andy mentioned, without paid family leave, without paid sick leave, without an ability for individuals, as Andy and Scott Gottlieb and others have called for, to have a safe place to convalesce and not to infect others. We can do many of these things that have been outlined and have created positive improvement, but without these structural factors that allow people to be able to afford to isolate, allow people to afford to get testing, we're going to have challenges. And one last problem I wanted to mention is just the cost of testing. Although Louisiana is doing great, one of the heads of our largest payers in the state said if we tested every individual along the lines of what's being suggested, it would double premiums by next year. And so we've really got to think about governmental solutions to testing, whether it's using public health labs or using stimulus funds to build public health infrastructure throughout the nation and allow for low-cost tests, or other solutions looking at sewage and other ways of looking at the genetic residue of COVID in ways that allow you to have early warning signs. We've got to look at cost of testing, and it's a major unmet need nationally. So I'll just stop there and hand it back to you and then to Jason.
Thanks so much, Dr. Gee, for sharing your on-the-ground experience and perspectives from Louisiana. And with that, I will turn it over to our last speaker, Jason.
Thank you. Good morning for those of you on the West Coast. Good afternoon to the rest. My name is Jason Elliott. I am a senior counselor to Governor Gavin Newsom out here in California. Thanks for inviting me to participate in this seminar today. I'm here to talk a little bit about Governor Newsom's response to one particular part of COVID, which is the homeless population. So I know we're going to have a broader conversation, and that's important, and happy to chime in where I can to help move that forward. But just to zoom down and narrow down on one particular aspect of this challenge, in California, we have 108,000 unsheltered homeless people. That is the largest population. We're the biggest state, largest population anywhere in the United States. 108,000, another 50,000 people that are considered homeless but sheltered. But let's just focus for a second on that 108,000. When we first were learning about COVID, mid-March, we were all trying to figure out what this disease was, how it spread, what the attack rate would be, what the mortality rate would be. And we were all learning, and we were doing our best to make educated guesses and learning from our health professionals. At that point, we were modeling a 56% attack rate in California. Then, in addition to that, we consulted with some homelessness and public health experts in California, and they told us to assume a 40% high risk rate for homeless people, meaning comorbidities, over 65, at serious risk of complications or death from COVID. So if you take 108,000 homeless people, you put a 56% attack rate against it, and you put a 40% high risk morbidity rate against it, you're looking at 25,000 homeless people in California who could become seriously ill or die. So when we were first learning about this disease and figuring out what we needed to do, the governor really quickly said, all right, well, we got to focus on this as one of our key pillars. Why do we have to focus on this? Number one, the humanity of 25,000 or 26,000 homeless Californians demands that, obviously, and that's first and foremost. But in addition to that, and more importantly for the healthcare system more broadly, a homeless person who needs to avail himself or herself of an ICU bed or a ventilator will receive the same treatment and access to care, ostensibly, that a housed Californian will. Which means that if we have 26,000 people, an extremely vulnerable population, all living in congregate settings that get sick quickly, that's going to overwhelm our hospital system to the point that at that time we had ICU capacity of between 10 and 20,000. So that was our entire ICU capacity, was just the homeless population. So it became clear that we needed to do something around homelessness. I'll spare this sort of narrative history of what we did, but I'll just jump to the conclusion, which is we implemented something called Project Room Key. And Project Room Key is a non-congregate sheltering strategy for homeless Californians. 75% cost share by FEMA, who has been a tremendous partner to us in this effort. And through Project Room Key to date, we've brought about 16,000 hotel rooms online and helped about 13,000, a little over 13,000 people move out of shelters, move out of encampments, and be in isolation in hotel rooms where they can be safe and other people who are continuing to live in encampments can be protected from the spread of COVID. As a result, we have not, and I will knock on every piece of wood in this office, we have not experienced a spike in infections in the homeless population that is dramatically different than our general population. We've had a couple of shelters here and there where you've gotten 100 positive cases that have all popped at the same time. Similar thing, though, that we're seeing in our long-term care facilities in our prisons. So Project Room Key largely has worked. The question now is, what do we do? Because that federal cost share may end at some point in the future, will end at some point in the future. We obviously, as every other state and jurisdictions around the country, we have access to CARES Act funding, specifically the coronavirus relief funds, which expire at the end of December if they're not spent. So I'll just speak a moment on what our strategy is moving forward, and then happy to answer any questions. So we continue to prioritize isolation and stability for the homeless population because that's what it's going to take to protect homeless individuals from COVID. So we're going to use about $600 million of coronavirus relief funding, which we've supplemented with another about $350 million of state general funds. So about $1 billion program to buy as many hotels and motels and vacant multifamily buildings as possible to convert them into stable housing for the homeless. So this is a $1 billion sprint of an effort. We're looking at buying thousands and thousands and thousands of motel rooms. And for those of you who are working with CRF right now in your communities, you know that this December 30th expenditure deadline is hard and fast. And so we're jamming as quickly as we can to make sure that we can buy as many of these hotels as possible and not revert any of this money to the federal government. So this is going to take a significant level of coordination and effort with our counties to buy these units. The counties will ultimately, we have 58 counties in California, the counties will ultimately own the buildings and operate them and provide services, either the county itself or through a nonprofit contracted entity to provide the services. And just last point on this, we, of course, permanent supportive housing in the homelessness space is the gold standard. You create a permanent place for someone to live with all of the supports they need to be successful. That's the gold standard. Not all of this housing is going to be permanent supportive housing. These units that are going to be brought under control through purchase under Home Key can be transitional housing and they can be interim housing, meaning let's get people off of the streets and out of those shelters, provide that safe isolation capacity, and try to continue to flatten this curve, especially when it comes to the homeless population, because they're so vulnerable and they just simply, I mean, it goes without saying, have nowhere to self-isolate. If they suspect an infection or are in fact infected, there's no home to convalesce in alone. So it's just simply the humanity of the question demands it, but also to protect our healthcare system for everyone else in California. this is the strategy we're pursuing. So we'll check back at the end of December, and I'll let you know how many thousands of hotel rooms we were able to buy. But this is our primary homelessness strategy for the remainder of this year. And with that, I'm happy to turn it back over and answer any questions. Thanks very much.
Thanks so much, Jason. And I know we'll all be closely watching to see how these efforts play out in California over the coming months. And another big thanks to all of our panelists, to Andy, Ryan, and Dr. Gee as well. We will now open the telebriefing up for questions. So please use the Q&A button at the bottom of your screen to type in your questions. We'll give folks a few seconds to get their questions in, and then I will turn it over to my colleague, Natalie Davis, to field those as they come in. And Natalie, whenever you're ready, we'll take the first question.
Great. Thank you, Kristen, and thanks again to the panelists. We have been getting questions in this whole time, so I'm ready to start. Just so to answer some of the questions that have come in, here are some links to the resources that our panelists have spoken about today. We also we are recording this and we'll be posting the video and transcript at a later date. So our first question comes in, Ryan, specifically about the data, but I'm sure others have feedback that they could give. Can you remind us on where you're pulling this data? When is it refreshed? Can we compare state by state given the different definitions of measures in state? And does testing include nursing homes, prisons, jails, private detention facilities, homeless shelters, et cetera?
So the data is refreshed every night, but every data source refreshes at a different cadence. So for tests, cases, deaths, and hospitalizations, that's every day. The data that comes for ILI is every week, because that's updated every week by the CDC. And then for ICUs and beds, it's actually 3 times a week on a Tuesday, Wednesday, Thursday cadence, but sometimes they update it another time as well too. And so at the bottom of the site, you can see when the last time we pulled data from each of these sources happened. And then the question from Amy around data is based on, is not normalized. Actually, some of our columns are normalized. So you're right, some columns aren't, things like percentages and true counts. But we do have things that are adjusted per capita, per million. The whole idea of it is so you could sort by columns, but also just to get a true sense of what's happening on the ground. Like that metric of new cases per million can truly show why one state has a larger problem than another. And then I think the last one was around PPE. We don't currently have the ability to aggregate that information because not all states report that equally. And so the COVID Tracking Project does a wonderful job of aggregating the bare data the bare data is the wrong word, the data that each state puts out. And so we really rely on them and their team. And so for the moment, PPE is not tracked. Contact tracing is also one of those things that's really hard to track as well too. But we have faith that as more states do this and publish it, through their channels of their public health departments and their state HHSs, they'll make it available on their websites, and then we can start to do something there.
But we still need more solutions on PPE. I mean, the supply chain issues were the supply chain was very broken when this epidemic first began, and there was a lot of confusion. It was an eBay type of environment with states bidding against states, and then FEMA, we'd finally find that we found a ventilator or a source of masks, and then FEMA would just come in and take them. There was a lot of confusion about who would get what, and there were political factors that influenced who would get what. The good news was that our hospital systems here in Louisiana partnered and worked together and helped share resources in ways that had never happened before. But we're still in a situation where we had to put masks in paper bags and reuse, and in some cases not have appropriate PPE, and certainly having our essential workers not have PPE and mixed messaging. So we should work towards more regional purchasing collaboratives, more transparency, make sure the federal stockpile is well indexed and it's communicated clearly what's in it. We did get at one point a very large shipment of things from the federal stockpile, but those things were expired years ago. So all of that needs to be looked at, and we need to prepare better and not have it happen again. And there are many different strategies that could be used, but right now I'm still not comfortable with where we are on PPE and ventilators and how we're doing with all of that.
Great, thank you. Kristen, I might start with you on this one, and then others may have something to chime in. As we think about moving into the fall with vacations over, schools opening, as well as flu and other natural disasters, what are, what are the things that states and leaders should be thinking about? And then perhaps Dr. Gee or Jason, you can speak to what this looks like from the state perspective to prepare for, this next kind of phase as we move into the fall and winter.
Mm-hmm. Sure. And I think it really starts first and foremost with the kind of close monitoring and tracking of the data that Ryan led us through with COVID exit strategy, is that states have to keep a really close eye on what the outbreak is looking like not just in their state, but in particular areas, even at the county or the local level. So they're able to respond quickly with the public health tools that we have when they do see spikes of the virus start to emerge. So they're able to move more testing resources to an area, really more contact tracing resources to an area. And then as states are doing that monitoring, I mean, really now is the time for them to think about what challenges they're going to be facing down the road. I mean, as we're seeing in the data right now, we're still in the early days of this pandemic. And so states need to be thinking about what resources are they going to need when schools potentially open or partially open, and how are they going to track spread from places like that? What is this going to look like when flu season starts and there will be potentially more strain on hospital capacity? Now is the time for states really to be thinking about how they can reach populations that maybe don't typically get their flu shots, to make sure that this year they're getting those, they're protected, and that's minimizing some of the strain on the health system.
Yep,
I'll just add, in addition to schools reopening, oh, sorry, doctor, go ahead after you, please.
Yeah, just to say, look, we've got to be aware of this push and pull. The scientists would have us shut everything down for months until the virus is totally gone. And then you have political factors and then you have real factors of the other epidemic. We've got a mental health crisis in this country. We've got millions of youth who have lost educational opportunities, and we have to acknowledge that those that don't have school and are more vulnerable or low income have parents that couldn't stay home and have the type of environment that people with more resources have. So there are externalities and consequences of canceling school beyond just the COVID epidemic. So I think we need to be pragmatic and think about these things. The National Academy will be coming out with guidelines in July, but also the industrial hygienists are coming with backtoschoolsafely.org soon. I can't give you a date, but these are the things we should follow. But also be pragmatic. Let's not go buy millions of thermometers and have people have a school nurse, as someone asked me, stand in front and wait for every child to come in and get a temperature check before school. We've got to do things like use technologies that upload the data automatically, or better tracking ability of other types of apps to be able to do this kind of public health reporting. We can't assume every school is going to have an epidemiologist, so we've got to think about that ahead of time. The issues of vaccine access are real. We just published data that there's been a 50% drop in presentation for heart attack and stroke at our emergency departments throughout the city. The same thing is happening with vaccines. Parents are not bringing kids in. So I think the push right now needs to be get your, in the fall, get your flu shot, get your checkup, stay as healthy as possible, and let's work to make sure it can be as successful as possible. The good news is the data show that kids are not the spreaders we thought they were, and that's promising. And we also know that kids do better when they get COVID. So all of that is good news, and hopefully will help us with school reopening for children in the fall. But we do know that college students are a problem. We just had a big outbreak with our kids that went to Tigerland Bar around LSU's campus. Kids they're not as afraid of COVID as older folks, but they can be super spreaders, particularly young adults, adolescents, and people in their 20s. So that's a population we really got to focus on communicating, the consequence of having parties and congregating. And so these fall reopening plans are really going to be important to the nation as we continue to fight COVID.
And I was just going to add that, just to put one more layer of complexity on top of this, for those of us who are in government, it's not just school that comes back in August or September. It's not just that's when the weather gets cold and everybody needs to be inside instead of sitting out in the backyard. For those of us in the American West, we got fire season coming up, and we're in the middle of a drought. And so how are we, as just an example, and won't dive too deeply into this, but how, just as an example, do we think about things, for Dr. G in hurricane season? When we know what we do during fire season or during hurricane season, you move everybody out, you do evacuations, you put everybody in a high school gym. Well, that's obviously not going to work this year. So as we have to start, fire season is an inevitability for us. We may or may not have a earthquake, but we are already in the middle of fire season or beginning fire season. So what do we do? And how does CAL FIRE, which is our state fire department, how does CAL FIRE prepare not only to keep firefighters safe, but to keep evacuees safe? And that's just one example of 5 or 6 others you can imagine where in government planning, we need to think about things because nothing can be normal course of business. We need to rethink all of those sorts of things.
Well, it goes without saying, thank you both for your service on making sure that the states and the country are safe. There's been a couple of questions that have come in that are looking at the changes in who's getting COVID with the median age going down. What does that mean? As we see an increase and people maybe aren't getting as sick, what does that mean? I know, Dr. Gee, do you have kind of insights that you would share on this?
Well, what we know is that older folks are more concerned and they've heard the message and people are staying at home more, and younger people are, and we just had a couple of clusters, graduation parties for high school students and so on. So I think this message of, we're doing this to take care of each other. It's not just about you, it's about our community is really important, and making masks cool. We're gonna have a mask brigade at LSU and do this in other campuses where people walk around in masks, and if you don't have one, we give you one, and it looks fun, and just making it part of being cool to wear a mask. But we've got to work, do a better job with young people, reminding them of why they have to stay at home. We're seeing these rates track up. I don't have ages in the data that I'm looking at, but the age range of coronavirus patients has tracked all across the age groups, except for people under 3 in Louisiana just don't seem to be getting this virus. So again, we really need to continue to message social pressures and positive reinforcement of good behaviors, because the COVID fatigue, I think, is worse for young people who have been so impacted by this. And so we've got to also find creative ways to get people engaged, and also just simple things. There are 3 simple things: stay 6 feet apart, wear a mask, stay at home when you can, but if you wear a mask and stay 6 feet apart, you can do a lot of fun things. So just, trying to reinforce this message. Wash your hands too. People are starting to not wash their hands as much, some of our data shows. So people just have to keep up with those 3 things: wash hands, hand wash, 6 feet apart. You can't get tired.
Great, thank you. Andy, you may have something to add here. And another question that came in: positive cases are going up, but deaths and hospitalizations don't seem to be tracking. Is that true? Your thoughts on this?
Yeah, I think I could combine those two. So first of all, there is some good news, which is that science is working, and all of the people who stayed home to flatten the curve not only took pressure off hospital capacity, but they gave our scientists real time to start working on some of the things that are starting to work. And there's therapies now that are being used to address oxygen levels, to address blood clots, to address immune system responses. And, when this was in Wuhan, 80% of the people that went into the hospital and were put on a ventilator died. That's now less than 50%, and I expect that to keep coming down. So the good news is I think this will become less fatal in general the more we have time with it. But here's the bad news. One is it doesn't hit everybody equally. So it is much more fatal still in some people than others. And so people that are lower risk, as Rebecca was talking about, are people that if they're less careful, it impacts others. The other thing is that there's pretty good reason to believe that this thing tends to circulate fast, first in young people, and then eventually find older people. And that in New York, because we didn't have testing, we weren't able to see it, but that there were a lot of people. We now know about a quarter of the population in New York that were infected early and didn't know it. And then the disease circulated and found older people, and then that's when the fatality rates went up. So it is not time to declare victory, because remember, deaths are a lagging indicator. And we're starting to see hospitalizations climb. We have 7 states now that have record hospitalizations. 20 other states don't even report hospitalizations, so there's probably more. And then I expect if, we'll be better than we were in New York, but in July, it wouldn't be at all surprising to see, unfortunately, death rates moving up. So anybody who believes that this is a safer disease yet we're not ready to declare that.
Great, thank you. This last one is a round robin. I have the privilege as the head of public engagement of talking to people across the country about their healthcare experiences. And during COVID, a fascinating trend that we heard was high anxiety, high concern, but also high levels of hope. And so for the people that are manning and womaning and taking on this, what in a very short way gives you hope to keep working on this every day? We'll start with, in the order of speakers, Kristen.
Sure. So I would say we have already learned so much about COVID. There's so much more that we understand, and there's so much that we can do to have better control of what this looks like going forward, both in terms of our response and then what we're sharing with people about that response.
Great. Andy, what gives you hope?
You're muted, Andy.
We'll go to you. Oh, you're on mute.
Sorry. Yeah. Okay. Yeah. This is a common experience for me during the virus. Is the unmute function. What is the reason to be optimistic?
Yeah.
New Zealand, Hong Kong, Czech Republic, Greece, Singapore, Vietnam. You look around the world. This is a virus that, if you have a strategy, you can live with it. And you can open the economy up and people can be safe. If you don't have a strategy, if you don't have an approach, it gets the better of you. And there's still an opportunity for us to have a strategy here. And that strategy includes some things that we control, like masks, and it includes other things that Kristen referred to that scientists will do.
Great. Ryan?
I think the biggest thing that gives me hope is, every day that we are doing this work, it's just seeing how much each state is really taking control of what's happening, right? Especially in the states that you see are switching to yellow to green, like how much ownership that they're having over the problem, how much they want to share, how much data they're putting out. It's really, really exciting to see. And so I just want and hope that momentum continues.
Ryan with the data. All right, Dr. Gee?
Yeah, so what Andy said about there is that winning is possible, but also masks give me hope. As I look across a country that's been torn apart by racism and inequity, and I see people marching together wearing masks. I go walk around New Orleans and people are wearing masks. It shows that people care about each other, despite the fact that we're in such challenging times. We love each other, we love our country, and we want to take care of each other, the vast majority of people. And so, their masking gives me hope.
Love that. And Jason, and then Kristen, I'll let you take it away to close.
Sure. So I've been in government about 15 years, and I think sometimes local and state government gets a bad rap. But I think what gives me hope, and it's to jump off of what Andy said, I've seen government and government people and civil servants and political appointees do things that you never would have thought local government, state government could do, whether it's buying millions, hundreds of millions of masks, whether it's doing this hotel program and getting 16,000 hotel rooms, whether it's putting this senior meals program we stood up in a matter of days, and now we've served almost 2 million meals to low-income seniors, and so on and so forth. These are things that would normally take months, at best years. And I'm watching government people do things in matters of days that none of us would have ever thought possible. And in order to have a strategy, like Andy said, and then to execute on it, we're counting on all those nameless, faceless civil servants that work in all those state and local governments across the country. And those people are heroes too. And I'm not talking about the political hacks like me. I'm talking about the folks who are doing the work, executing the contracts, and providing those services. And there's a whole army of public servants out there that give me a lot of hope.
Well, thanks so much, everyone. That's a perfect note to close on. A big thanks to our audience for joining us today, and a special thank you again to all of our speakers, both for sharing your time with us today and for all of the work that you're doing every day to help make this better for everybody. As a nonprofit organization, work like we shared today with all of you is only made possible through the donations we receive from individuals, foundations, and businesses. And if you would like to join our important community of donors, you can make a gift directly on our website at unitedstatesofcare.org/giving. You may also find other resources in addition to what we discussed on what we discussed today on USofCare's COVID-19 hub, which you can find at unitedstatesofcare.org/COVID-19. And as always, follow us on Twitter at USofCare. Thanks everybody and have a great day.